Planetary Health First, Mars Next, a Michael Mann production. We are on a mission to transform healthcare, one where all equally benefit by building a dynamic, robust, diverse community. Join us on this journey. One parsec at a time, we will be transforming healthcare together. Welcome, everyone. Happy Thursday. We are here live on Planetary Health First, Mars Next, and we have a really amazing guest. I'm so glad that Tom and I connected. We have Thomas Campanella, Tom Campanella, and we're going to be talking about healthcare disruption. And so there's going to be winners and losers. Tom's going to guide us through this, but let me just give a little background why this is so important and why we are so lucky to have Tom here. Tom has 35 years in healthcare. I would say that's a good amount of time to see anything and everything. And why is this so important that Tom's here is because he served in many capacities in healthcare. He's got more degrees if he kept them. He's got a JD. He could have still had a CPA and then a few other things, probably an MBA. He can get all that soon and verify it and correct me. But anyway, why does this matter? Well, he's had 35 years specifically with health insurance, physicians, and hospital sector. He was a former vice president of a health care finance and care management at Blue Cross Blue Shield of Ohio. So with that being said, he learned everything of getting paid, working with all the different departments and teams. So if you're running as a VP of a health plan, you got to know just about everything and anything. And so he also was at one of the big six as a healthcare certified consultant as a CPA, which he'll tell you more about. He let that go. And he's been a former dean, a COO of Ohio University College of Osteopathic Medicine, and a COO at that place at that organization where he was leading 5 multi-specialties clinical sites and 40 physicians. So he knows that's just one other part of where he is knowing and seeing healthcare. He currently is associate professor. You were a former associate professor. You have a new role, which we'll get into that in a soon bit. It's hard to keep up with him with all he's done, but he is served as associate professor at OU, taught healthcare finance, healthcare economics, and managed care to undergrads, graduates, and medical students. And I'll let him share a little more what he's doing right now at Baldwin Wallace, but really it sounds like he's leading the charge as the executive and resident there, and really just communicating everything and anything about healthcare, covering many of these topics just like he's going to be doing today. So much to do, and I think I've said enough. Tom, please correct me for what I said and what I shouldn't have said. Go ahead, Tom. Great to have you here.
Michael, thank you for inviting me. And basically what I love about my background is, as you said, the diversity, both, educationally, I have both the economics, legal, financial with the CPA, but in regards to the healthcare sector with over 35 years, I've been on the consulting side, payer side, with Blue Cross of Ohio, now Medical Mutual. Been on the provider side, both working with hospitals and with the clinics that I was involved with the medical school. With Ohio University's medical school, I got involved with medical students. And then I've done consulting. I've been a healthcare attorney. So a little bit of everything. That's what's so cool about healthcare. There's so many different directions you can go to. And probably one of the proudest that I have is really in regards to the teaching end, towards the end with my relationship with Baldwin Wallace University. The students in our program are from all different sectors of healthcare. And when I was teaching classes in health economics or policy or law, I never knew when I was the professor or the student, because these students were physicians, people from the payer side, medical device, pharma, and they were bringing real world experience into the classroom. So it was really a cool win-win all the way around.
Well, we're going to have to get this ball rolling
Sounds
because
good to me.
we got a lot of topics to cover with healthcare disruption. So if you want to just go ahead and get it started, and what are the causes of this, and why don't you share more about this whole dynamic of this, what's going on with healthcare disruption, Tom?
Well, Michael, first of all, when you think about disruption, it's really in effect change in the status quo, from a definition standpoint. And as it relates to healthcare, there's been major disruption. Actually, it really started prior to COVID, and COVID really escalated it, and it's continuing now. In effect, as it relates to healthcare, bottom line, we've been always facing a challenge of escalating healthcare costs. Those challenges were great. And when you think about the payers, it's the Medicare, which is the government, Medicaid, state government, you had employers, you have consumers. So they're all, in effect, been impacted by high healthcare costs. Well, the end result, though, is those escalating healthcare costs have got to the point where all of those payers on the governmental side, non-governmental employers, consumers are basically saying we've had enough. And so they're basically going out there and, in effect, creating, actively getting involved, trying to address their healthcare costs. As a result, it's twofold occurring. One, if you happen to be an incumbent, you're basically, in effect, being challenged because of the healthcare costs in different ways. And at the same time, it's creating a lot of opportunities for new and innovative organizations to get into the healthcare space. And remember, healthcare is about 20% of our gross domestic product. So there is a lot of money in healthcare. And so ultimately, a lot of players are going into it, challenging incumbents in different ways, and we'll talk about it later. And that's what's creating a lot of the disruption that we have today.
So how are the various healthcare sectors impacted by the disruption that is occurring in healthcare?
Well, it's in different ways. And in many ways, I think, when you think about it, it really creates a challenge for them in their day-to-day business. And I think we can get into it because, we have a lot to cover today. Really, the incumbent hospitals are probably the most impacted by the disruption that we're talking about. And reason why, one is they're the biggest. And number two, the big focus or the main focus of this disruption is trying to make our healthcare system more value-based, from that standpoint. And in effect, hospitals have been, and trying to keep people healthy is, ultimately the primary focus that we're trying to transition to. So ultimately what we're trying to do is transition from a sick care system to a real health system. It's been a slow process. We're going in the right direction. Well, again, the biggest incumbent in the sick care system is hospitals. So I think, we'll be talking now about, some of the specific challenges hospitals are facing as well as some of the other healthcare stakeholders.
So we're talking about winners and losers, and what are some of the key stakeholders that you'd like to share more about, just to lay the groundwork?
And why don't we just start off with hospitals, Michael? So we go with hospitals, and hospitals are, one, we all have a vested interest in a strong system of hospitals. The challenge that they're facing is both in regards to who's paying them. Think about who's paying them. They're getting paid by Medicare. They're getting paid by Medicaid, which comes through the states. They get paid by employers, and then they get paid by consumers. All of these stakeholders, payer side, have been financially challenged even prior to COVID in regards to escalating healthcare costs. COVID has accelerated those challenges, both for the federal, state government, employers, and consumers. And that challenge is resulting in even more of financial heat, where they're then saying, okay, hospitals, you need to be able to be even that much more accountable. So for an example, on the hospital side, even prior to COVID, payers were pushing to try to get health care being provided to patients in the lowest cost setting that is also safe. And so they've been trying to push more and more out of the inpatient setting, which historically has been the big moneymaker for hospitals. So they're pushing care from the inpatient because it is the highest cost setting. And even prior to COVID, they're pushing it to outpatient and what I call the new frontier of healthcare, care in the home setting, which actually did accelerate a lot during the COVID time period. So then put yourself in the shoes, because I like doing role playing. Put yourself in the shoe of a hospital president or a hospital CFO. Now, on the inpatient side, you're in effect having payers pushing things out of there, and they're pushing them into arenas of outpatient and care in the home setting, where there is a lot more competitive forces that they have to face. Because a competitor coming into a region, it could be in North Carolina, Ohio, anywhere, the idea of building a new inpatient facility and challenging incumbents is pretty difficult, both from a resource standpoint, as well as people have traditional, loyalties to the incumbent hospital. But as more care gets pushed to outpatient, as well as care in the home setting, you can have, if you're a hospital, competitors that are local, regional, and national in all different forms. And that's what's starting to happen. So they're starting to lose a lot of their market share from that standpoint. And it's creating a real challenge for them financially as they're trying to survive.
So what do hospitals need to do to not get disrupted out of business?
Well, part of it is they really got to change their business model. First of all, and I'll say this a few times, this disruption that we're talking about that's occurring in healthcare is really, healthcare is late to the game. There was disruption in the 1980s with the auto industry, when the Japanese and others came in with Toyota and the Germans with Audi and that to compete against the big three auto market. And that created major disruption in the auto industry, which resulted in plant closings. It resulted in people being laid off and losing jobs. But ultimately the end result, we came up with a better car. There's been disruption in the banking industry, the steel industry, the retail industry, with the Amazons and that. So the one thing I do want to get across here is disruption is the natural evolution, where you have, both incumbents and you get new players, and that's where you get the value. That's part of the outgrowth of a competitive market. So hospitals then need to recognize that, one, this is not unique, and two, they can't continue to operate with the old business model. They have to transition. So what do they have to do? One is, historically, they have high fixed costs. And as hospitals try to compete in outpatient or care in the home setting, and there's been more and more push for price transparency, and payers are saying, we want to be able to see the price differences between providers, just like you would do buying a computer or cell phone. They then have to find ways to become more competitive in those markets. So they got to address their costs. There's different ways to be able to do it. Every hospital's going to be able to have to address it in different ways. In some ways, if they can't do it themselves, they may have to outsource or collaborate with third parties who are much more efficient in doing that to become more effective in this. And this occurs all the time in arenas outside of healthcare. It's just that healthcare has been so entrenched, especially with the hospitals, in regards to it. They're not used to this type of competition, and it's creating a lot of challenges for them. So just
I
before we get into
go ahead.
practices, I just want to echo this: is other things that hospitals can do, in regard to it. I mentioned before, they can outsource to sort of relationships that allows them to more work with value-based providers. Say they can either outsource vertically or horizontally. So if they're talking vertically, it might be their computer systems or other types of things that they do in-house. They may wind up outsourcing that. Employees that used to work for the hospital may wind up working for a third party that has a business relationship to the hospital. They may decide that, from a vertical standpoint, physician groups that they've owned or physicians that they've owned as employees, or in regards to particular lines like a rehab line or that, rather than having them all owned, they may decide, okay, we might release some of these physicians and we can't afford their fixed salaries. And they may wind up having a collaborative relationship with the hospital, but being independent. They may establish a relationship with a for-profit entity for rehab services or that, rather than owning it themselves. So they need to do different things to become more efficient, really what it comes down to.
So I'm hearing that hospitals really need to be strategic at looking at every little line, every business line, whether should we go alone, should we go together, partnerships, what can we do? So gosh, what position or title would that be at an organization that would be leading those initiatives at a hospital?
It would definitely be a team effort, between the CFO for sure. Most hospitals have somebody over strategy, for an example, so they would be playing a key role. And then, and they really have sort of that executive team. And really, a chief operating officer obviously, plays a critical role from that standpoint. And then, and they really then need to come together and say to themselves, okay, what we got to do is, one, on the inpatient side, say, okay, what can we do not only to become more efficient, but if hospital inpatient admissions are going down, the other phenomena that is occurring, Michael, is the acuity of the patient, how sick they are. When they do go to inpatient, they're much sicker than they were before. So they're facing sort of a much more sicker patient. And so one way that they can sort of benefit from this, if their inpatient services are more focused on high-risk individuals, they may be able to package these and become a center of excellence in the region and try to get referrals from other hospitals that don't have that capability, or from outside not only the local region, but even on a national basis. So they try to find different ways to be able to do that. But you hit it on the head, Michael. They got to be strategic.
It sounds like it's real. It sounds like it's really very difficult right now for hospitals, because what you're dealing with is decisions based on humans and the intelligence. And we just don't do too well at that. Change. I mean, we all know change is the most difficult thing, but to get the right insight that then get the, death by committee. I know you know a lot about that with academia and all the different titles and positions. It just seems like, I feel a little sympathetic for these hospitals and their challenge that they do in order to with being innovative and how to go ahead and transform themselves.
Well, as I think one of the keys, and as I post on LinkedIn and I do other ways, with white papers and blogs and that. And one of my key messages, I started one blog recently about hospitals, in effect saying I would not want to be a hospital chief financial officer during these times. It's, it's got to be really tough. Not only you have changes, but you may be letting people go. And, and that emotionally can be really, really tough. The other challenge is, human nature as it is, Michael, you don't, you sort of want to say, well, let's keep things what let's not make these changes. we did well in the past, let's stay in the past. Well, the longer they do that, in the long run, the fall or the challenges they have are going to be much greater. But human nature as it is, just as you said, with committees and everything else, you may not be willing to make those tough decisions, and tough decisions need to be made.
So I guess before it gets too old, like this comment that I put up on the screen, really about primary care, I guess that's really regarding the independent private practice, kind of like what, my dad's 90 now, he's retired, his practice is still kind of, anyway, that's another thing, but it's just, it's probably like a lot of other physician practices, but I'm looking forward to your reply on that. I have a feeling what you're going to be talking about, but go ahead and tell us I think you're going to say on the other hand with primary care, but let's hear what you have to say about primary care and the independent physician practice.
On the other hand, no, what it comes down to is we just talked about, I think there's going to be opportunities. And in fact, in primary care physicians historically have felt that they've always been at the bottom of the totem pole. And but when you think about primary care physicians, Michael, and your dad was, obviously, and continues to be one of them, is that if you're transitioning to a value-based system and you're trying to keep patients healthy, what specialty on the long term plays the biggest role in that? It's primary care. Mm-hmm. If you're trying to engage individuals in their own health and you're trying to establish a trusted relationship that allows them to really sort of transition to become more proactive in addressing lifestyles and those types of things, well, you have to have those long-term relationships. And who really has that? Primary care physicians. So everybody wants primary care docs now. They're in unbelievable demand. Hospitals obviously have been buying them up, and a lot of reasons to be able to refer to their specialties at the hospitals. But now the payer side, United with Optum and others are getting in, and they're trying to acquire primary care docs. But then at the same time, there's models out there. One that I really like and I've written about is called direct primary care. And what this is primary care docs basically saying, you know what? We don't want to be owned by anybody. We don't want to be owned by the payers. We don't want to be owned by the hospitals. We want to stay independent, but we know there's some challenges there. So one way to do that is they wind up establishing their independent practice of primary care docs, and they try to establish a relationship with individuals. Concierge medicine is one way to do it. But I think the most effective way direct primary care can work is, we were talking before about employers facing escalating healthcare costs. Well, what if the primary care docs, practices in that, collaborate and have an alliance with the employers within their community, and their big focus is trying to keep the employees and their dependents healthy? Now, all of a sudden, employers who actually do pay for health care are getting a direct benefit of it, because they have a proactive group of doctors, in this case primary care, that is out there working with them to look at the health issues across the board with their employees, designing programs and that proactively does that. The other advantage in aligning with employers is that, one, comes down to employers are obviously focus a lot on productivity and a lack of absenteeism. Well, if you have those direct primary care relationships, part of where their focus is to keep people healthy, addressing those back issues, whatever it is, so they can continue to be going to work. So, and be productive individuals. So they have that particular ability. The family members that keep you away from work or something like that because they're sick or that, if they're taking care of it. And so the employers would help pay for the fees of these primary care docs, and then basically be in a position where they really get the benefit. Then they can go out and rent a relationship with either an insurance company or some other provider network for specialty referrals. But then the other big advantage of the primary care doc and direct primary care is they would then have data available to them in various ways to be able to refer patients, or in this case, employees, to value-based providers. And so there's a real benefit there, and I see a big future there for them.
That is fascinating. I have a few questions, but I don't want to get off topic. I was just thinking of payment reform with the payers at some point. But let's go into another interest. What does all of this healthcare disruption mean to like the medical device and biotech sectors and other stakeholders, really regarding the supply chain?
Well, first of all, people don't reckon. All you have to do is go on LinkedIn if you really want to know. And how many people, people think, healthcare, and they think everybody works for a hospital or an insurance company. And there's so many different sectors in healthcare, including in this case, the medical device biotech sector. Medical device and biotech, for an example, historically have had a real strong linkage with the hospital sector. And going back to what you were just talking about payment reform, the way that relationship really blossomed for them, it was sort of we've historically had what I call fee-for-service arrangements, where payers, including Medicare, Medicaid, even your insurance companies and that, would pay providers, in this case hospitals, for the services they provided. And then from a self-interest standpoint, I'm not saying it's being done inappropriately, but it really came down to the way providers, including hospitals, made money is the more you did, the more you made. And so the more utilization of technology and everything else, the more money you wound up making. Well, all of this was great news for medical device and biotech because they were part of that supply chain. So they had this free-flowing dollars coming in there. Now, as we transition from fee-for-service, because we're doing that because of the high escalating costs, to more of a value-based, risk-based, outcome-based type reimbursement methodologies, now the medical device, biotech, and other sectors along that supply chain, they then have to be that much more value-based. And they have to be, because, for an example, we were saying hospitals are facing a lot of competition. They need to address their fixed costs. Part of their fixed costs in the services they provide is on the supply chain comes from the medical device and the biotech sector. So they'll then be demanding more value from them. So it's a domino effect, all the way down, just like it occurred in the auto industry, banking industry. It's sort of that focus. And all of this in the long run, even though it's creating disruption, really just like we do with computers or cars or anything else, the end result will be, I think, a more value-based purchase from a healthcare standpoint, which we all are looking forward to.
You bring up about the med device and biotech sectors. It seems some hospitals, health systems are also looking at that as partnerships with revenue, greater revenue with different aspects. I know it's fascinating. I don't want to name drop, but I do know that a lot of these healthcare organizations are utilizing alliances to extend their reach and revenue with the med device and biotech and all the different research. So is there anything that you can share a little more about that you've seen as a driver for revenue?
Well, what's happening is, and it really is, they're trying to do a win-win here. For an example, medical device and the hospital sector. They need to find ways to become more value-based, both of them, and they sort of feed into each other, from that standpoint. And payers, including Medicare and Medicaid, are also focusing on better value, outcomes, better outcomes, overall, and they're measuring outcomes. So the bottom line then is hospitals, for an example, instead of dealing with lots of different medical device companies, may develop a strategic relationship with only a few. And they then will sort of work together to become more of a value-based services. So for an example, knee replacement, back surgeries, or others, shoulder replacement. Well, they then say, okay, there's, it's both hospitals, their skill set physicians, but there's obviously medical devices involved. What can we do to make sure that this is more efficient, that there's a better quality outcome? What can we do together to collaborate from that standpoint? So that's what's occurring there. Payers too have a vested interest, and they may establish a vested relationship with, some payers like United and others might say, you know what, we're only dealing with certain labs or whatever for lab services. Well, they may say, you know what, down the road, they're not necessarily doing it now, but they may establish, sort of a collaborative relationship with medical device or biotech. So there's a lot of, this is just the start of all this disruption and evolution. So there's a lot of different ways that this goes. The other part of this too, Michael, is healthcare is local. So you can't just listen to this and say, and look out your window and say, yeah, but that's not happening in my neck of the woods yet. Well, it may be happening somewhere else. All I'm saying, eventually it's going to happen all over, just like, again, what's happened with banking and other types of areas from a disruption standpoint.
Tom, I'd love to talk more about long-term care because that is an aspect of healthcare. We've seen huge challenges with long-term care during the COVID, time, and just would like to know more about where you see disruption and the disruptive forces with long-term care and these stakeholders in healthcare.
Going back to the business model change that we talked about hospitals, there's a real parallel between hospitals and long-term care facilities. And where I'm going with this is, for an example, we just talked about how on the inpatient side, on the hospital, we're pushing things out. Well, the same thing is happening with when it comes down to, wait one second, I apologize.
So we're talking about long-term care, and go ahead, take it away.
Yeah, I had a spotlight on me called the sun. And but basically there's a parallel there. So just like payers and others are pushing care from the hospital inpatient to outpatient care in the home setting, what's happening in the long-term care side is that a lot of those services are being pushed out of the long-term care facility. So for an example, skilled nursing, institutional skilled nursing, the major profit source for long-term care facilities, that have both, custodial part, the nursing home side and rehab. They've made historically lots of money in that area. Well, what's happening is payers are pushing that to go more towards the home setting. So in effect, it becomes skilled home care. With the other thing that's happening too, with advances in science and technology, we now have the ability, and this is why home care is really growing. I call it the new frontier. We have the ability to diagnose, provide, and monitor care in the home setting that we didn't have that ability maybe 5-10 years ago. And that's evolving like crazy. So now we have the ability to be able to push a lot of those skilled facility cares and everything to the home setting. And you have that. A lot of long-term care facilities may not have home care, and so they're sort of stuck there. The other part is just like with the hospital inpatient, the people that are staying in the in the skilled nursing side of it, they will have much greater risk factors. So in other words, they can't be cared for in a home setting. So each long-term care organization has to evaluate their staff as well as the technology they use to say, okay, now we're going to have a much higher risk individual that needs rehab than we had before. And, do we have the staff and the equipment to be able to handle it? So that's part of the challenge. The other challenge that they'll be facing is seniors, not only because of cost, people, payers are trying to push people to the home setting in regards to, say, like Medicaid, where they used to be in a nursing home and now they're getting home care at home. But also, people's preferences is, I want to age in the home. I want to age in the home set. I don't want to be in the nursing home. So you have that occurring. So now a long-term care organization whose main source of income is both in regards to institutional skilled nursing, the rehab part, as well as custodial with the nursing home, are seeing financial pressures from both sides as care is being pushed to the home care side. And, so they're getting hit by there. So they got to become that much more efficient and really change their business model. What I feel real bad about is, one, the people that they will be getting on the, say, the nursing home side will be much sicker, much more challenging for this. And one of the biggest challenges, even prior to COVID, for the nursing home industry was their staffing, just like with hospitals with nursing. And, and I know so many people that are in, that have family members in the nursing home setting, and it's a tough job that these people face on a daily basis. And now they're facing even more with people with, major clinical as well as, behavioral health issues. And so that will be a big challenge because there's major turnover and everything else. So they got to really evaluate. Some of them may not make it. They may have to decide to collaborate with third parties. They definitely got to be more innovative. Now, the one growth area for long-term care organizations going along the continuum is getting into sort of senior housing, where need be, because people want that sense of, or independent housing. So they may be able to provide that because they might be in neighborhoods and, you have a member, or assisted living. There may be areas there where you can provide that in the home setting, but if you have the right attractive thing, people may want to live there in that type of setting because it really doesn't have that nursing home feel to it.
Mm-hmm. Well, let's move over to how is this disruption in healthcare impacting entrepreneurial companies as well as venture capital and private equity investment in healthcare?
It's growing like crazy because, as you can imagine, in disruptive times, it's really disruptors that are really, in effect, picking up market share and making money, but they need financing. So now all of a sudden, private equity is going big time into healthcare in all different diverse sectors. You're getting, venture capital. You're getting Fortune 500 companies that are getting involved in it, like Walmarts of the world and others. So they're all, Amazon and that. So it's creating a lot of business opportunities, and they're making a lot of money, from that if they are indeed very market based and their product is needed, just like anything else, in regards to what happened to the cell phone industry or the computer industry or any of those other areas there. So those disruptors, need the financing. The for-profits are coming in big time, and the incumbents are the ones who currently have the market share. They're the ones being challenged, like hospitals. And so that's why they do need to reinvent themselves.
Seems like we've seen some challenge, though, of recent with this layoffs, a lot of these layoffs in digital health companies. And the ones that I've seen are challenged that were backed by venture capital were really struggling with revenue and struggling with, business models. It seems like that's in spite of all the opportunity in healthcare, it seems kind of ironic. There's been a lot of losers in that space as well.
Yeah, just because you're the new kid on the block doesn't mean you're going to be a winner in it. Again, Where's BlackBerry today? They were the first ones innovative back in the 90s in regards to cell phones. You have a lot of other organizations that were sort of looked like on paper, the big .com thing of 1999 and 2000, when the market went really crashed because you had, different type of companies that were innovative in that. So you gotta, ultimately, even if you pick up a lot of customers, if you're not making money, you're not going to survive. So there will be winners and losers in all of those. But the whole theory about the market system is that the winners and losers, the end result of it, the winners will ultimately be, more value-based. Now, of course, too, this is where government comes in, and they step in different areas, and they're doing it with Facebook and others, the antitrust part of it all, because the big challenge in all this is you get one of the mega companies that literally buys up the market, and then they try to, in effect, destroy all the competitive forces. So that's where government and Justice Department need to be watching the whole scenario too.
Yeah, I think what you're talking about, we see a lot, and I can't name all the different companies, but throughout the years, you have Facebook and Amazon, and especially Apple, when a company gets to be about $500 million and they just buy it up as a threat. They just buy those companies up. So, you've got the big 5 or 6 tech companies that really dominate, the trillions of dollars really are going into their pockets.
Well, the pharma and biotech, they get these small little companies that come up with a nice little product and they get gobbled up by the big boys. So you're right.
Well, I would love to move over to the provider side. So is this healthcare disruption only impacting the provider side of healthcare? I know we've talked about others, but just tell us a little bit of your take.
Well, you have the provider side, then you have the payer side. And the real payer side, and people recognize it, would be your Uniteds of the world, the Anthems, some of the big payers, the big 5, if you want to call them that. And then there's obviously regional payers out there. They're also facing a lot of disruption from that standpoint. And a lot of that is what's happening in healthcare from an employer standpoint. We mentioned from them going from passive purchasers to active purchasers. Well, passive in the health insurance business for employers is, sort of health insurance is itself. So compare health insurance to your car insurance. You pay a premium once a year. You could have some accidents, but your premium doesn't go up. Obviously, in future years, it could be depending on your accident record. Self-insured is that, and by the way, and fully insured, the payer, in this case, say it's the State Farm or whatever, if you're talking about car insurance, they are taking on the risk if it's the car insurance. On the other hand, as it relates to health insurance, the health insurance company, United, Anthem, and that would take on the risk. What's happening, though, more and more employers, and even smaller employers, and some of them are coming together in coalitions, are going self-insured. And what that means, they're taking the financial risk, and they're just hiring administrators, which could be a United or an Anthem, or could be a third-party administrator to pay the claims, do the discounting, have the relationships with the hospitals and other providers, from a network standpoint. But the bottom line, these self-insured companies are taking the risk, financial risk. They will have a relationship with a third party for stop loss for high-risk claims to protect themselves there. Any claims over $250,000, say, gets covered by the stop loss, and they pay a premium for that. Point, though, is because they're having the risk, they're much more proactive. And because they're much more proactive, they're basically challenging the big insurance companies that you got to provide me value because I see my costs going up, and I actually see it. It's no longer out there. And then I'm seeing this price transparency that's coming, including the federal government pushing it. And I see lots of opportunities out there, and you can't have a cookie cutter approach. Health insurance companies historically, the way they make money with a lot of companies, unless they're mega, 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 is a cookie cutter approach. They basically say, this is the way we do it. This is our product. This is the hospitals that you go to. These are the physicians. This is how we pay claims. You know, these are the way our benefit designs are set up. It's a take it or leave it type approach. And they are now facing competitors that are coming in and saying, you know, employer, self-insured employer, we're willing to adapt to your needs. We're willing to be flexible to meet your specific employer needs. And if the big insurance companies aren't able to do that or don't want to do it, they're going to wind up continue to lose market share. The other issue that's impacting, just as an aside, the big profit for the big five, if you want to call it, you know, the Anthems, United, Cignas, and Aetnas and that, has been especially Medicare Advantage, as well as Medicaid managed care, which is through the state. They've probably 50 to 60% of their profit comes from Medicare Advantage. Well, there was a lot of publicity about this over the last year or so, where CMS, the Center for Medicare and Medicaid, the governmental agency, is saying, you know what? We're paying Medicare Advantage plans like United way too much money. And so they're going to be putting even more pressure on them financially to be able to, you know, sort of cut back their payments and that. So they're starting, just like on the provider side, they're going to be seeing disruption. They're going to get less reimbursement. They're going to be facing more competition, and they too will have to evolve. So we'll see what happens. There'll be winners and losers in that sector.
You know, this is sort of a side, but I saw something posted that the average health plan cost for a family of four was like 31,000 posted, I think I read, but I just feel like I'm getting the short end of the stick every year. It's like the cost of the premiums go up. I try not to use healthcare and I don't get anything. I would love a plan. I don't want to say United for all, but my gosh, it'd be nice if there was a 401k sort of thing where you carry it. If you don't spend it, you get 2,000 saving or 3,000 and you keep it for life. And you actually might have a few $100,000 in 30 years of retirement. It just seems like it's just, you know, that the rate and the expense just keeps on going up. So when you figure that out, let me know.
Well, you know, in fact, just as an aside there, and I'm, you know, everybody has answers. Now, will they be the right answers? Who knows? But I'll give you an answer. But, you know, the point is, for an example, a health savings account fits in the point that you were just talking about, where employees can get money put into that, where they contribute tax-free, employer contributes some money, and then they can use it on health. And that's a great way. It's efficient, makes them more involved in the healthcare purchase, the employee. And as you said, if they do a good job of managing this and they stay reasonably healthy, they're in a position where they're able to carry this forward to other employers and also invest it if they need be, and actually have a nice little fund, you know, for them to be able to do. So there's a big push doing that, and that's still occurring. So there's all these forces coming from all different perspectives, which is creating all the disruption that we're talking about.
So we've been talking a bunch about disruption, and I'd like to go a little more further. How is this disruption impacting individuals that work in the healthcare sector?
Well, that's part of the challenge. I think there's both, like anything else, there's opportunities and challenges. My perspective, and I recognize when you're going through it, you feel like Chicken Little, the sky's falling. Like, oh my God, you know, they just laid off some people. And I've gone through this in my career. And, you know, they've laid off people. There's every Friday, you know, you get called up to somebody calls you up to human resources and you're saying, oh my God, is that going to be my job or not? So, you know, there will be challenges. But at the same time, my philosophy is in times of disruption, it creates the best opportunities for employees to be able to demonstrate their value, move up in the organization, or move to organizations that recognize their value. So bottom line is, if an organization, I don't care what it is, healthcare or not, is fat and sassy, making a lot of money, then you could be the best employee and they may treat you the same as that average employee. But if that employer is going through, in this case, healthcare, a lot of financial challenges and looking for solutions, and you're an employee that can help address those financial challenges and come up with those solutions and make that a more, successful organization, you're going to do well yourself. So I think this is the time really to not only look at as, as a negative, but as an opportunity to show the value I can provide. And I'm a big believer, and it's not just education, but I think individuals, in this case in healthcare, need to invest in themselves. They need to recognize and believe in themselves and demonstrate their value. And if it's not working out in the organization they're with, then they need to look to other organizations.
That's great. Yeah, always being upskilling, learning the resources, networking, developing more of those skills where the healthcare is going. We're coming towards the end. Are there any takeaways, any sort of things that you would like to just share with our audience? Any last comments?
Well, I think the big thing it comes down to is that, it may seem, if you were listening to this or viewing this, is that if I'm an incumbent, say working at a hospital or working in a big insurance company, oh my God, we got all these players coming and trying to take our market share. And, and you sort of have that negative takeaway from what we've been talking about. But innovation, and this has happened in other sectors, doesn't necessarily always need to come from those disruptors, those new players. If your organization can evolve and become more innovative, more value-based, both perceived and actual value, recognize and go through the necessary business model changes, then you really can succeed. So there's a win-win in all these cases. My key message, though, is you can't hold on to the past. You got to recognize that what's happening now in healthcare happened in other sectors, and it's going to continue. And you got to evolve both organizationally and individually.
Well, Tom, this has been great. I am so grateful that you were able to come today and share with our audience about healthcare, about the disruption in healthcare, the winners and losers, and really appreciate it. And we're going to just say our little goodbye here. Friends, it's been such a great journey today on Planetary Health First, Mars Next. Feel free to follow us. Just type in Planetary Health First, Mars Next on the internet. Until next time.